Hey everyone, let's talk about the hypertensive medications. If you're looking for the overview of hypertension, it's in another video. This video lecture is just going to talk about medications for hypertension. All right, well, first I want to just let you guys know and start with this. There are a lot of blood pressure medications or hypertensive medications. You know, I know there's a lot of them, and if you look at your book, there's like 3 pages of them. I know there are a lot. Are we going to ask you about every single one? No. However, you are expected to know the most common types and the classifications of them, one or two at least, the most common of each classification. Try not to get too overwhelmed with them. I try to make it as simple, give you kind of what they do, and then just focus mainly on what makes them different. Because honestly, they all lower blood pressure. We know that they are meant for that. That's why they're called antihypertensive medications. However, there's a few things that are distinctive from each of them, which is mainly what we want you guys to focus on. All right. So another thing that you want to consider when you're looking at them is sort of what is the nurse need to know when they're administering these medications. That's what mainly your instructor is going to ask you also at clinical. Hey, you're about to administer one of these. What should you know as the nurse? How do you know it was effective? And what do you need to monitor during the therapy of any of these medications? So there's 5 classifications: the adrenergic inhibiting drugs, the ACE inhibitors, the ARBs or the angiotensin 2 receptor blockers. We also have the calcium channel blockers, the vasodilators, and the diuretics. And all of them are common. Now, yes, we do have combination therapies where perhaps, let's say, a ACE inhibitor is mixed with a diuretic. That's very common, but we want you just to focus on mainly the main classes. All right, let's look at the adrenergic inhibiting drugs. So we have alpha A's and we have betas, beta blockers. The alphas mainly deal with the blood vessels. They work at the blood vessel by not allowing the vessel to constrict. If we have a narrow blood vessel, the blood from the heart is pumping against something that is higher resistance. So therefore, we don't want none of that because that's going to elevate the blood pressure. However, if we inhibit the blood vessel from constricting, we have a narrow, sort of in a little bit, not dilated, but a little bit of more open vessel. And the force that we're pumping against it, it will be lower, therefore lowering blood pressure. The beta blockers, they work in the heart, the frequency, how fast is the heart pumping. They also inhibit this fight or flight, which affects the constricting of the vessels as well. So they work a little bit in the blood vessel, the heart rate, and then indeed, they lower blood pressure. So just giving you a little bit of patho here. So for the adrenergics, we have clonidine. Um, Now, let me tell you, these and INE, iodine, most of them, or sosin. There's another ending for them, sosin or iodine, or inine. Now, clonidine is very common. It comes in a patch, it comes in a pill. It's very potent. It will drop your blood pressure very quickly. Very effective. Now, we also have doxycycline, which could be used for urinary items as well, but it does lower blood pressure. It has that alpha component to it. Um, Now, in the betas, they end in law. So low blood pressure. So atenolol, bisoprolol, metoprolol is very, very common. I tried for my common ones to give you like a little star by them so you know they are common, and as well that you're listening to my lecture. Carvedilol is common as well, Coreg. And then propranolol is sort of a beta non-selective. And so we got to be careful with these non-cardioselective drugs because they're contraindicated with asthma or COPD patients because they work in they affect the constriction of the bronchi. So we got to be a little careful. Now, here's the thing with beta blockers. They no longer lower blood pressure, but they lower the heart rate. It affects the frequency of the heart, of how fast is going. So we got to be very careful with these clients because number one, we cannot administer them if their heart rate is less than 60. Your book talks about 60 heart rate. However, I will tell you that in practice, you could see maybe some orders written by physician hold if less than 50, okay? But your book, and we're going to go by the book, it says less than 60. 60 beats per minute. That's number one. Number two, another thing with these beta blockers is that it sort of mask your diabetic patients when they're showing signs of hypoglycemia, because one of the signs and symptoms of hypoglycemia is tachycardia. So if you have a diabetic patient on a beta blocker, they will not experience tachycardia. So you might miss, right? Thinking that they could be having low blood sugars. Okay, so think about low blood sugar, low heart rate, your laws, your beta blockers. Okay. Um, these are also very commonly used. These beta blockers are commonly used also in heart failure patients. So you're going to see them not only for hypertensive, but for heart failure. And honestly, guys, we see a lot of these meds also used for heart failure in hypertension. When you are deciding, okay, is this medication being prescribed for heart failure or is it being prescribed for hypertension? You kind of need to know or sort of figure out or kind of see it in this way. Okay, well, maybe it is a beta blocker for lowering the heart rate because my patient has heart failure, but also because of blood pressure, because we don't want high blood pressure on a heart failure. Or let's say maybe it's a diuretic, but in this scenario, we have a heart failure patient with a lot of fluid buildup. We're excreting fluid with the diuretic. And we'll get to diuretics here shortly, but I'm just letting you know that most of these are used for both heart failure and hypertension. Okay, then we're moving on to the angiotensin converting enzyme, or we call them ACE inhibitors. Basically, we have this enzyme, the ACE, that converts angiotensin 1 to angiotensin 2. Now, what that happens is why is that important is because when we have angiotensin 2, it creates a lot of vasoconstriction, and also um, it basically inhibits the aldosterone, which in the end we need, or it causes the patient not to vasoconstrict. So in that result, we have a more open vessel, which then lowers blood pressure. But also, it doesn't allow aldosterone to be secreted, and aldosterone is responsible for retaining sodium and water. We don't want that either because that equals sodium and water equals fluid volume. So that's why here on my slide, I put the result is to decrease blood volume fluid by decreasing sodium and water or not retaining sodium and water due to aldosterone. And then decrease of blood pressure by not vasoconstriction. Okay? Just trying to make it into simple words here so you can understand it. These end in prill. So the ending of them are going to be prill. One of the most common that you're going to see is lisinopril. This one, oh Lord, it's very commonly used in the hospital. But they all end in prill, quanapril, benacepril, ramipril, etc. Now, they all cause blood pressure drops, right? We established that. But here, some different is that it not necessarily is going to affect your heart rate. All right. But it does not affect your heart rate frequency. However, it can affect your kidney function. Okay. So we need to monitor kidney function. We need to see what the creatinine level is. And they also can elevate potassium. So it can cause hyperkalemia. So, for example, you might have someone that maybe has a urinary tract infection, develops acute kidney injury where their creatinine bumps to maybe 1.8. That's a little high on their creatinine. Well, you might want to hold the lisinopril because their creatinine level is elevated. Or you might want to hold the lisinopril because their potassium level is elevated. They should not be given with NSAID or aspirin because those two are a little harsh on the kidney. And there's some very interesting adverse effects with ACE inhibitors, um, such as main common is this hacking cough. It's non-productive, it's annoying, it's just hacking patients. As soon as they start the therapy, they start experiencing it. And as soon as they stop the therapy, the hacking cough stops, okay? Another very adverse effect that is actually more serious is angioedema. Angioedema is whenever they swell up their lips, it can lead to a complete blockage of their airway. And so it could be potential fatal. Okay, so we do need to um, watch out for that. Now, we do see angioedema more commonly seen in African Americans, and I'm not sure why, but they are more prone to the angioedema effect. Um, but it could happen on really anyone. Other side effects are fatigue, dizziness, and headache, and mood changes, as well as impaired taste. But those two, the hacking cough and then angioedema, are sort of like very hallmark to ACE inhibitors. All right, let's look at angiotensin 2 receptor blockers. They're called also ARBs. Now, here we're not blocking um, the ACE, what do you call it? The converting. Okay, so the ACE, we're actually blocking the receptors. Um, So instead of acting on the enzyme, the ACE enzyme, we're actually blocking the receptors on the angiotensin 2. The result is the same. If we block those receptors, it's not going to convert from angiotensin 1 to angiotensin 2. And therefore, we're not going to have vasoconstriction or retaining sodium and water from the aldosterone. So the result is the same, but it works in a different part. We're not working on the ACE enzyme, we're working on the receptors of the angiotensin 2. Now, these end in sartan. losartan. And I try to remember ARBs with sartan because it has the AR, sartan, ARBs, you know. That's a way you can remember them too if you want. Losartan is very common, as well as valsartan and olmesartan. Those are the most top three commonly seen in the hospital. Here's the deal with them. They lower blood pressure. We know that. They still mess up with the kidney, so we gotta watch out for kidney function and potassium. They also need to be avoided with NSAID and aspirins. However, these have less adverse effects, okay? They don't have that hacking cough that makes ACE inhibitors be commonly what do I want to say? Like a lot of patients, they stop sort of the therapy because of that, because of the hacking cough. So patients are non-compliant because of it. So these have less of those annoying adverse effects. And if someone, for example, has a failure on ACE inhibitors because of the cough or the angioedema or whatnot, they might switch them to ARBs as a second sort of chance at the therapy because they still do the same. Now they're a little bit more expensive, financially cost, they're a little bit more expensive. So with these, some of the adverse effects are they can cause fatigue, same. They could cause hypoglycemia, urinary tract infections, anemia, and diarrhea. Okay. Now, A's and ARBs, you can use them with diuretics, and you will see them commonly used with diuretics. And again, they are very commonly used for heart failure patients as well. So careful with the kidneys, and therapy does take 3 to 6 weeks to start or to see results, and they cannot be given with NSAIDs. All right, let's talk about vasodilators. All right, so vasodilators they work great because, if we have a vessel that is wide open, very dilated, and relaxed, then my heart is not pumping, against a lot of pressure. And so therefore, we're going to drop the blood pressure. We decrease that vascular response, that vascular resistance, um, and you drop blood pressure. Now, some of them are very potent, let me tell you, and very effective because of that. So you have your number one commonly used is hydralazine. Now, hydralazine can be given PO, IV, and it is potent, guys, okay? Very potent. If someone is not reacting to other blood pressure medications and you give them a little bit of hydralazine IV, boom, it usually does the trick. So yes, vasodilators do lower blood pressure. We know that, it's established. We know that. Now here, what the difference is that because they're so potent, you got to think about loss of safety, okay? Loss of safety. Not that you don't have to think about the other ones with safety because they do lower blood pressure, but these are going to act very fast. Um, so think about keeping them in bed, rising slowly, not combining them with erectile dysfunction medication because it's going to cause a lot more vasodilation. You got to warn them about hot weathers and warm and humid because it could lead them to syncope. They could also cause this flushing and headaches because of the vasodilation. They might get a little red, flushed, and you want to monitor for edema. Okay, but for edema. So those are the kind of like the little things that are different. hydrolysin. Now, within this classification is also nitroglycerin, and we talked about nitroglycerin with angina patients. Okay, so we might use this classification for hypertension as well as angina. And then that isosorbate monotrititrate is a long-lasting vasodilator. All right, moving on to diuretics. And I love this picture here of the dog peeing because that's exactly what they do. They pee all the fluid, okay? So basically, this medication is going to work on fluid volume and also eliminating sodium, but in that in that process, you lose potassium. Now, we do have two that are um, um, two diuretics that you lose potassiums. They're called the loop diuretics and the thiazides. And then we have one that is called the potassium sparing diuretics that you hold on to potassium. Okay, and I will tell you here shortly which one it is, this potassium sparing diuretics. But make sure that you write that you make a note on your notes that loop diuretics and thiazide diuretics, they lose potassium. They lose potassium. Okay, let me looking very quickly at your book. With here my pages flipping because I want to see if your book says anything about them. No, no, no. Okay. All right. So let's look at the loop diuretics. These are probably the most common ones that you're going to see in the hospital. They end in nide and mide. Furosemide, bumetanide, and torsemide. So mide or nide, lose potassium, lose fluid, pee a lot. They pee a lot. So now with these, you always think about safety. For all diuretics, you think about safety because you're lowering their blood pressure and you're losing fluid, so you can become dehydrated as well as having orthostatic hypotension. Um, Now, as I mentioned, you want to monitor electrolytes because they do lose potassium. So if let's say you have a client with a potassium of 2.2, that's low potassium, you want to hold this medication. Most often, you see patients on loop diuretics and thiazide diuretics. You see them on a potassium supplement. So they basically give you potassium PO as well as your diuretic PO. Now, another thing that they could do is that we encourage the patient to eat a potassium-rich foods. If they're taking supplements or they're not, they could still eat foods that are high in potassium, so you can sort of replace it. Another thing with loop diuretics is that they can cause ototoxicity, so careful with that, okay? That ringing in the ears, and all the symptoms of ototoxicity. Let's look at thiazides, and these end in thiazide. So that's how you're going to recognize them. They end in thiazide. And most common is hydrochlorothiazide or chlorothiazide. Again, they lower potassium, they lower blood pressure, and you want to give them with supplements of potassium and high rich foods, potassium rich foods. And they're encouraged not to take them with NSAID products as well. Now let's look at the potassium sparing diuretics. Now make a note on your notes. These potassium sparing diuretics, they hold on to potassium. So instead, here we don't have hypokalemia, we have hyperkalemia. Okay. And you want to monitor their potassium level. And if it's high, you want to hold it. It is also contraindicated in kidney patients. And we got to monitor those kidney functions very quickly, very often. Sorry, very often, just like we do with the loops and the thiazides. Okay. Now let's talk about nursing considerations in general for all for all antihypertensive medications. Let's start with, you gotta teach the clients to monitor their blood pressure as well as their heart rate if it's applicable, like in beta blockers. You want to make sure that you teach them about safety. So, um, for example, for diuretics, something that I would teach the client would be, hey, try to take it during the day so that way you're not peeing at night as often. Because if the patient is getting up to go pee at night, they could stumble and they could cause a fall. So we want to give these medications early during the day, as well as changing positions slowly, raising slowly, because of the potential effect of orthostatic hypertension. You also want to make sure that you teach them about the high potassium foods for the thiazides and the loop diuretics. So I gave you here some foods that are high in potassium, such as bananas, potatoes, tomatoes, orange juice, salt substitutes, yogurt, etc., milk. So you can teach them about that. And then not only that, but also recognizing, well, how can I tell if a patient is having hypokalemia? And, so some of the signs and symptoms of hypokalemia are muscle cramps, muscle weakness, constipation, fatigue, tingling of their arm or fingers, arms, legs, and toes. So that way they know, ooh, maybe my potassium is low. Maybe I need to, you know, take my supplements of potassium. Maybe one in the morning, maybe one at night. Um, Also, when we look at diabetics and beta blockers, I'll say it again, we got to watch out for their heart rate. And hypoglycemia, it masks the tachycardia. So they're not going to experience tachycardia. They're literally not going to have tachycardia. So you might miss that they're having a hypoglycemia event. You also want to tell them, hey, you should not double the doses, especially if you're vomiting. Let's say the patient took their um, beta blocker and then they're being sick and they vomit. You never want to double the dose. You want to consider and call the doctor and further get instructions by them. You also want to teach them that, hey, these medications such as vasodilators um, should not be given with erectile dysfunction medication because of the risk of more hypotension. So we got to be careful, right? Also, another thing to consider is that a lot of the blood pressure meds, especially beta blockers, they do affect the sex drive on individuals. So, especially on my males, they might stop the therapy because of that. So, allowing them to express and really ask those questions um, about. Hey, have you noticed this? Is this something that you're experiencing? Well, please do not stop your medications abruptly. Let's go ahead and talk to your physician to see if we can get you a different medication. Okay. Uh, I mentioned the hot weather and the hot bath, and last, knowing and reminding them that drug therapy is not the only part of the therapy for hypertension. They need to combine diet, exercise, stress reduction, weight loss, stopping alcohol, stopping smoking, and just eating a better diet, less of fat and less on sodium. And usually the sodium recommendation is 2 grams a day. Okay, so 2000 milligrams or 2 grams per day. Okay, well, I hope this was helpful as a review of your cardiac medications for hypertension. Remember, focus on really what is different instead of, kind of, oh, well, they all lower blood pressure, but what makes them different. And I will see you in the next video. Here are my references. Bye-bye.